Thank you, Andy, and thank you, Jan and the rest of the team for the opportunity to present what, to use the reality TV vernacular, has been a journey. I'm going to talk a little bit about the Royal Surrey and how we increased minimal access options for our HPB patients, and then talk about how we then developed that into the introduction of robotic surgery, talk about the current status of robotic HPB at the Royal Surrey, and then talk a little bit about our pathway. I'm quite keen that we're not lecturing on how the right thing is to how you get robotics into your hospital, because every hospital will be different. But I think we can probably look at where we feel at the Royal Surrey we did it well and we did it badly, and hopefully we are standing on the shoulders of giants who have already done the laparoscopic journey for us and some of the robotic journey. If we can contribute a little bit more to the pathways being easier in the future, then that's great, and then we'll come to some conclusions. So this really relates to the Royal Surrey as it was at the beginning of our robotic programme. It's a 520-bedded district general, co-located with a cancer hospital, which has an extensive tertiary practice in a range of cancer types, and also has an extremely high-performing, minimally invasive colorectal unit under the lead of Prof. Tim Rockall. It was already a robotic training centre for gynae-onc and a proctoring centre for urology, and at the time we were starting we had 2 XI systems and an SI. We also have an on-site minimal access training centre called the MATU, which has a long history of teaching, particularly laparoscopic colorectal. We also, at the Royal Surrey, were very lucky to have enhanced recovery embedded in all of our specialties. It really has been, since the early 2000s, it's been a major focus of our anaesthetic department, and I'm really delighted that Geeta Agarwal, who will talk later, one of our anaesthetists, will talk through that side of our pathway. But essentially we started with a median length of stay for elective colonic resection of 3 days. That's for anterior resections. The right side is generally out in 23 hours. And a median length of stay for elective liver resection, this was all comers open, and the small volume of minimally invasive we did of 4 days. So we started from a pretty good point in terms of enhanced recovery. And from about 2018, we started to increase our minimal access options. So this is HES data. I'm not a big believer that HES data tells you the absolute thing that's going on, but I think for the trend it's often quite helpful. So moving from 2018 to the latest quarter, 22-23, you can see we increased our minimally invasive rates from about 14% up to now, when we're offering minimally invasive liver operations to about 38% of our patients. We did this gradually. We've heard from Mo and others about how what you don't do if you're going to do this is go, I'm going to go and do a trisectionectomy tomorrow laparoscopically if you've never done it before. Initially, the decision to offer lap resection was based only on surgeon preference, but as we progressed through the programme, we realised that actually we needed to change that model so that upfront decision-making was made. If suitable patients that would contribute to the learning curve of the surgeon and be laparoscopically feasible came up, they needed to be allocated at the referral stage, and we did move towards that. And all 6 of the surgeons at the time offered lap resection, but only 2 offered lap hemihepatectomy. We stepwise escalated. In 2018 we did 24 cases, 7 of them were for benign pathology. In 2021 we did 32, including 7 hemihepatectomies. So we reduced the amount of benign pathology we were doing, which are really just learning curve cases, although they have advantages as well, but then we progressed to major resection. We've evaluated now a total of 124 cases for outcomes, 16 benign and 108 malignant. We had 9 conversions, all of them in the malignant group. There were no conversions for bleeding, interestingly. I'm not sure how I feel about that, because actually that might suggest we weren't brave enough. It depends on how you read into it, but essentially we had a few conversions for more extensive disease than were appreciated despite up-to-date imaging. 3 we couldn't get into laparoscopically, 1 impenetrable adhesions, and 1 chap who developed a profound physiological reaction to the pneumoperitoneum with a hyperlactatemia and acidosis. He is this person. It later turned out he hadn't been out of the armchair in his house for 6 months, except to come to his pre-op assessment where he'd said he was fit and well and walking 5 miles a day. We learned from that though. So, median follow-up of 25 months, we had an overall recurrence rate of 20%, of which only one patient had recurred at the resection margin. 2 patients recurred systemically, i.e. in the lungs. 17 had at least 2 sites of recurrence, but our median length of stay for the laparoscopic cohort was 2 days, and our ITU stay was 1 day, but the median length of stay was 0. We had no correlation between difficulty index or minor versus major classification and length of stay, which was a bit of a surprise to me. But I guess, again, probably indicates numbers and also the build-up. When we did the multivariate analysis for what affected length of stay, the biggest thing that affected our length of stay was whether you went to ITU. Regardless of whether they did anything for you, if you went to ITU, you stayed longer, and it was significant. So we learned from the lap expansion, and we said this is oncologically safe. We needed some other kit. We needed to decrease our ITU use, redesign the ERP, and so we moved on to robotics. Just a quick slide about variation. You can't force a surgeon to work a way they don't want to, so we were entirely comfortable sitting in a unit where we had one surgeon who did 11% of his cases lap and one who did 69% of their cases lap. And we were entirely happy with the variability, because you can't make a surgeon do something that they can't do. So we planned the robotic pathway. We had a pre-start consultant meeting. We decided what we wanted the pathway to look like. We talked about who would train in what order. We talked about how many of us would train, how we would ensure that there was equality of access to all consultants, how we would importantly provide robotic cover for every list, and how we would provide more than one consultant for difficult or first-time cases. And we agreed a priori that we must monitor our outcomes and development. So we trained in pairs. The first 2 consultants were those with the biggest laparoscopic experience, the second pair was the next highest, and the final pair was pretty much decided because the 7th consultant in our unit decided he didn't want to do it anymore, so that gave us 2 more. And we aimed to develop the first pair to level 2 GBIHPBA cases at the same time as the second pair started level 1. And the idea of that was poor Jawad was running around the entire country, and if we got him in for a week, we were lucky, so we had to make the most of it. We booked all 4 surgeons for the start of their programme before we touched our first robotic case, so we knew what our timeline was. We looked at simulation scores, case obs, TR100s, all of this is familiar to people who've looked at the GBIHPBA stuff. Importantly, what we said was that during the first pair's proctoring, the patient-side assistant should be one of the second pairs to train, because actually that still gives people a useful perspective on robotics while they're going through the process. We made great efforts to make sure we made the most of the proctoring time. So we cancelled an elective case and put an inpatient acute case on, just so we kept enough cases on the proctored list. Yeah. Then we did 12 more unproctored cases and got the proctor back down for the proctored level 2 cases. The second pair proctoring, we actually made a decision that the level 2 cases would be sort of not proctored but developed in-house as double or triple consultant operating. We're very lucky all 3 of our systems have dual console capability, which makes a big difference. Yeah. What was the challenge to progress? Access. Access is the biggest single problem to progressing your robotic program. The existing robotic teams are happy to be seen to help people get onto the robot, and they'll say, of course we'll give up time for your proctoring. But then when you start asking them for regular lists, it gets a little bit more fraught. I'm also a clinical director as well as a HPB surgeon. It's taken me 18 months to get to the point where all of our robotic HPB surgeons have regular access. There was a bit of a recognition that the 4th gen Da Vinci systems gave better outcomes to the urology and gynae patients than the 3rd gen, and that put a lot of pressure on our 2XIs. It had an impact on our regular operating. We had a training requirement for assistants, and sorry Jawad, proctor time. You were too busy. So how did we sort our access issues? Well, we had a really robust approach to saying, if you're not using the robot, if you're doing an open case in a robot theatre, you need to move that case and you need to free the robot up for someone else. We were able to demonstrate, because we'd insisted on monitoring our outcomes, we were able to demonstrate that HPB robotics was working. Within the department, we had to be really flexible. We had to offer to cross-cover each other's list, and we had a ready-to-go business case. And that was really important because late in March 22, some capital expenditure dropped off the Royal Surrey's budget. Happened to be about the same price as upgrading one of our the SI to an XI, and we had a business case ready to go. We filled that hole, and we got the third XI in March 22. This is what happened to our robotic cases, and this demonstrates what I was saying. This is during proctoring, when everyone said, of course you can have our lists. This is when they realised we wanted it regularly, and our case volumes dropped to 4 a month. This is when the third XI arrived, and we instantly saw a pickup. This is data from Intuitive, looking at our pre-HPB start. So the important bar, this is the SI system that we had, and these are the 2 XIs. So our 2 XIs were already doing about 70 to 80 cases a quarter, which is pretty good in the grand scheme of things. But the SI was almost completely unused. And now if you look at what we're achieving now with the third XI, all 3 of our systems are essentially in use the whole time, and per quarter we're achieving in the order of about 300 cases across all the robotic specialties, which is testament to everyone working together to use the robot correctly. Your case volumes as a surgeon will drop while you train. You cannot avoid that. You have to give up that time to do learning curve cases. You can't start with a distal, you can't start with a hemihepatectomy, you will go back to doing gallbladders. And we found that all our surgeons experienced a 50% drop in level 2 or 3 cases for the first 6 weeks after proctoring. Interestingly, your recovery predicts your eventual volume. The surgeons who take the longest time to get back up to where they were before with level 2 and 3 cases are the ones who maintain the volume, and it's because, probably, they're prepared to make the sacrifice of doing the learning curve cases for longer. All the surgeons get back to the mean once they're able to do level 2 cases on the robot. So you will get back to where you were, but you have to take the hit. And you do need to distribute the cases. You'll need to redistribute those level 2 and 3 cases to colleagues. You'll need to do fewer of them yourself, but it's probably not for as long as you think it needs to be. It's probably not for months, it's probably more like weeks. We monitored outcomes after 90 cases. We found that even in the group we didn't expect to help, the low complexity level 1 cases, we were doing, we'd saved 50 overnight stays in hospital and 14 ITU bed days, and that made the case for our third XI. That slide alone we took to management, and they decided that upgrade was the way they wanted to do it. Next. So currently we have 5 of 7 surgeons trained. The training is planned for the 6th, and as I mentioned, our 7th surgeon is choosing not to undergo formal pathway training. We've done 180 total cases. We've started doing level 3s, mostly hemihepatectomies. We now have regular access for HPB for 10 lists a month, with other access negotiable on top of that. And we're doing joint cases with other specialties, particularly colorectal and cardiac. That's taken, as I say, 18 months to get to that point. What we think we did well, we collaborated as a unit with the rest of the hospital, with the other specialties. We monitored our data, we made sure our cases followed where we all were on the learning curve, and we had a real clarity about what our pathway was going to be. What do we think? What do I wish we'd done differently? I wish we'd sorted access before we started. It would have made my life so much easier. It was probably not possible until we got the third XI, but I'm going to say it again, access is your biggest barrier to developing a robotic program. I probably would have progressed the second pair to level 2 cases a bit quicker. I'd have sorted out assistance and training, and alongside that comes what I think is going to be the biggest issue for robotic HPB, which is how we train our registrars. It's going to be a huge problem. I don't think, and I agree with Mo and the other speakers, I don't think you can ignore the fact that you have to be able to do an open Whipple to progress to robotic. All the papers say you must be through your learning curve on open. And if all these cases start disappearing to the robot, if the registrars start jumping on the robot, it'll be the same as when you need to convert any other high-risk procedure. You'll be looking at an open abdomen and going, I've not seen this before. This is going to be the big issue. We need to work out how we're going to train the next generation. I asked our other specialties, they're quite good at training. They train obstetricians and gynecologists, and they train urologists. And Trish Patel, who's one of the senior urology proctors, said, this is how you design a program: sort your access, train your whole team, never work in isolation, either within your unit or your hospital, and keep pushing the outcomes, keep pushing what you can do, but make sure you're keeping an eye on the safety as you do it. So in conclusion, we tried to introduce a pathway on GBIHPBA lines. It works, it made sense. We laid the groundwork really early. You have to monitor your outcomes, because if you don't, someone else will. You must work as a team, but you must accept that that means some people will go a bit further, a bit quicker, and you must be realistic about what you're going to achieve. It is unlikely, I would argue, that all 6 of our surgeons will have sufficient volume to all be doing independent robotic work. But we probably need all 6 of them trained so that we can do it as double consultant procedures. This is a small part of the team. These are all people who have directly impacted our robotic program, but I wanted to leave the last word to one of our patients. Thank you very much.